But one of the things that's been kind of near and dear to me, and for those that have actually been involved in our fellowship, is the whole issue of operating room efficiency. Everybody talks about speed, but speed often comes from not doing things you don't need to do, how you set up your OR. So to start the panel, Cliff, we'll start with you. Just introduce yourself and kind of tell us who you are, and we'll just pass it straight over to Doug.
Is it? Okay. Yeah. There we go. Now I hear it. Hi, I'm Cliff Hume. I'm at the University of Washington Medical Center and also at Seattle VA, Puget Sound. And what else do you want me to say?
Anything?
I'm hoping I'm going to learn something about efficiency
Anything
here.
Interesting about you? Just be creative.
I'm not sure if there's anything interesting. I'm going to talk about dizziness later, which is super interesting, so stay tuned.
I'm Andrew DeJong. I'm from private practice in College Station, Texas, and I've known Doug for too long. He was my chief resident, and anyone needs some dirt on him or stories, please come see me, and I'll fill you in.
You stole my punchline there. Chris Raine from the UK, Bradford Royal Infirmary.
He's Chris, I'll interpret. Chris Raine from the UK.
Yeah. Yeah. Yes, Howard. Yeah. He's got his name badge on. Can't you read it? Yeah. Yeah, so we have a National Health Service, so it's free at the point of contact. So all this talk about packs and volumes and things like that, very interesting. Yeah, okay. And reusing your balloons, wow.
I'm Doug Ruhl at Madigan Army Medical Center in Tacoma, just south of here. And I think it'd be interesting to talk about efficiency in kind of comparing the government and civilian hospitals and in different stressors. So
absolutely. So to kind of get this going, how many people in the crowd operate in an ambulatory surgery center? And how many people operate solely in a hospital setting? So for the people that are in an ASC, do you notice a difference between the ASC and the hospital? Okay. So of the panelists, how many operate in an ambulatory surgery center? Okay. And then 2 don't. So what have been the differences that you've seen, Andrew, between the hospital? I mean, is the hospital as efficient, less efficient, and what do you think makes the difference?
No question that an ASC can be much more efficient for you. I think there's many reasons for that. I think one of the big focus is that it's patient-centric. You often can focus just on the patient. You can make decisions much more rapidly, and so you end up being much more efficient just because even though the volume is higher, you're able in a smaller group to make decisions that are actuated much more quickly.
Chris?
Well, I'd point out, whilst we're in a tertiary hospital, we have a day case unit, so it's a difference between, if it's an ambulatory care, you're walking in and walk out the same day. The vast majority of ear surgery and cochlear implants, things like that, are done as a day case. So it's really what you call it, as opposed to, do you shut your doors at 9 o'clock and you have no staff whatsoever? We have staff 24/7, but the day case unit is open at 7:30, closes at 9.
Yeah, so it's very interesting. Another question for Chris. There was a Wall Street Journal article talking about the NHS and the financial struggles the NHS has. And when you get into a public health system, it's much more about wait lists and people getting access to care. So everybody's covered, but there's a wait list to care. And right now I was reading that there was roughly about 1,650 people on the wait list for surgery overall in the UK before COVID. And that number is now 470,000. And so is the NHS engaging in all different forms of sites of surgery like ASCs and operating rooms to try to catch up?
Oh, yes. I mean, even during COVID, we...
I'm going to have you guys talk to them.
We subcontracted to the private sector. So we had what called super green hospitals. So they're all properly screened. And obviously, I don't know what you had, all your various COVID rules and regulations, but you had to be sort of 72 hours isolated and things like that. So they came in, but if you had a complication, you couldn't go back to the green hospital. You'd have to go back into the emergency units. So we developed lots of techniques to stop people coming back. But I think a lot of our problem is access to beds. So the day case unit is protected because nobody stays in overnight. If you have to stay in, you go into the main body of the hospital. I think a lot of the politics we're seeing now is you can't move people out because of the poor social care structure that we see within the National Health Service. So it's a lose-lose at the moment.
So, Doug, when we're dealing with the military, so you also do some work on the outside with multi-care, is that right?
That's right.
Do you notice a difference between the two systems? Is one more efficient, less efficient?
Yes and no. I think that on the outside, very transparent on what my average case duration is and how does that compare with averages. And so the start and stop time are in my face on monthly reports. In the military hospital, I don't see that. I think that there's, because of maybe the absence of billing in the military hospitals, that outcome is not measured as well. Ideally, we talk about it, and it's in our staff meetings where we try to shed some light into it, but it's not as easily accessible in a non-billing environment. And in the outside hospitals or the private practice hospitals, they tend to have the same people in my room, the nurses, the anesthesia providers, the scrub techs, and so we can kind of build a very constant team of these are the only people that work with this surgeon. And it's ideally happens in the military setting, but it changes often. And so we have to be mindful of that. If there's a unusual case or a big case, kind of behind the scenes, find out who is going to be in the room and say, any questions on the preference card? This is what I want. And to think ahead, similar to your point as well, sometimes we have bed space availabilities where we have to keep that in mind, and we have to probe the ICU and say, this is my case, please hold a bed. Things that don't necessarily have to do as much in other settings.
And so I think that really would be point number one that I'd want to drive home, and that is, at least in the state of Washington, we have captain of the ship legislation. So if anything goes wrong in the operating room, it's the surgeon's fault. You're responsible for that. But also, the success of the operating room for the day depends on the surgeon setting up the team appropriately at the beginning. So when I say we, I use the generic we. William Klingscales is my current fellow, and William comes in the morning at the ASC, meets with the team, looks at the schedule, and they say, okay, we've got certain cases following. How many have devices? Have we checked that the devices are here? We think this one might be a little longer, this one might be a little slower, and you build an expectation with the team. I think where you lose a ton of efficiency and a lot of time is when you turn to your team out of the blue and say, this is going to be another 45 minutes, and they didn't anticipate it. The other thing is, we have very consistent scrubs in the ASC because we hire them, they're our employees. In the hospital, it's fairly consistent, but all of them appreciate asking for what you need next with 30 to 60 seconds for them to do it before you need it. And so we'll say, okay, we're doing a stapes. Okay, I'm gonna open with the pizza knife, let's say, and then I'll need a round knife in just a second. So they're looking for that piece of equipment. And if that person doesn't know the equipment, it gives them more time to figure it out or more time to help you. The other thing that's very helpful is to take the instruments you're gonna use in order and lay them out for them. And then any deviations, they can find them, but 80% of the time it can be very efficient. So, Cliff, is this something that you've put some thought into, standardizing your sets of instruments? And I mean, how do you support your staff to be better?
So it's a little, I'm at the VA hospital and also at the University of Washington. And so I think both locations they're slightly different. There's some similarities, but I think what's already been mentioned, I think that ideally, if you have the same team in the OR, it makes a huge difference. Not just because they know what instruments you use, but also because they sort of anticipate the flow of the case. And it's not like you're asking for things they don't know what they are. And I'd be curious to see what you all have heard, but with some of the recent Joint Commission reviews, for example, they don't let us mark our instruments anymore. And so the instruments all used to be marked with color coding and so forth. So if we had a floating scrub, they would come in to do a case. Maybe they never did ear cases. They would come in and say, oh, a double red is a round knife or whatever it happened to be. Well, that's no longer allowed. So they take all the labels off all the instruments. So now if we have somebody come in who's not familiar, they really, I can't even tell the instruments sometimes unless I look under the microscope. So it becomes very challenging. So I think with those kind of changes, it is helpful to restrict the instruments if you can. At the VA, I'm the only otologist who's working there most of the time, so it's not an issue really there. But at the university, there's multiple people who are using instruments, so we have to kind of accommodate, different people's preference. So that gets to be, I think it's useful for the scrubs to kind of cross-cover people, but it also becomes more of a challenge because people do things slightly differently. So, but I think in terms of instruments, that's a key thing, is to try to minimize the extra instruments that you don't need. Especially that can be an issue, again, with sterile processing, which we have a huge issue with also with the VA. In terms of bending instruments, breaking instruments, losing instruments. And so I think having fewer instruments that can be easier to keep track of can be helpful. So and then breaking down the sets maybe into just a couple sets, so like a sort of a standard basic ear set, and then maybe some other instruments, for example, for a cochlear implant that you might use, or in my case, I have a separate endoscopic set that we don't necessarily always use. So I think that those are some things that I would think are helpful.
Yeah, so I think, that's point number 2, and that is, really going through the surgical sets. A lot of you who particularly operate in hospital systems, you've probably come about a set of instruments that you inherited from another doctor or other people have used them. And when I was at Virginia Mason years ago, I was one of the first groups to go to Japan and study the Toyota production system in healthcare. And two things I noticed is that I was twice as tall as any Japanese sensei, but they were bigger than me. Number 2 was they were all about removing what you're not going to use. And their standard is if you use it 80% of the time, it should be in the set. If it's something you never use or you haven't used it in the last 3 months, take it out of the set. If it's something that it gives you the willies thinking about taking out, shrink wrap it. And if that shrink wrap isn't open in the next 3 months, take it out of the set. If it's used twice, put it back in. And the leading creep we saw of instruments being put back in were by scrub techs who were afraid the surgeon was going to get mad if they didn't have it. So we took 175 micro instruments for skull-based surgery, reduced them to 20. And it creeped back to 45 before we figured out what was going on. So again, really getting the team up to snuff. I agree, Cliff, you're really minimizing the instruments. How many instruments do you really use on the operations you do? Probably 5, for most operations. So kind of getting that down and then keeping it consistent and monitoring it. So Chris, in the UK, where you have such infinite control of your operative theaters, how do you do that? Are sets standardized through the UK? Do you build your own? How does that work?
Well, yeah, you've got simple myringotomies, we've got Baja sets, it's very simple. And yeah, the sets are minimum. They've got a middle ear set and a major ear set, same with the head and neck. So it might sound semi-commercial, but our sterilization goes out to off-site, and you get charged the number of instruments per tray. So there's an incentive there, I presume, to be a bit more efficient. But also, you have the Who check. You count your instruments in, you count your instruments back out. So it all takes time if you've got too many instruments. And I was saying, give me what I need, not what I asked for. And if you work with a team that we have, they're very loyal. They understand what you're doing. And I would agree with you. You probably only have about half a dozen instruments doing a laryngoplasty or even a cochlear implant.
It's fascinating is we went back and actually studied what were the delays, because the instrument set leaves the operating room and you don't know what the heck's going on. I mean, there's huge turnaround time. And I want to point out the first 2 points that we've raised have been physician issues, right? Preparing the team, picking your instruments. So we still haven't got anything to blame on the scrub techs yet. But we figured out that it takes 45 seconds per instrument just to spray it with the desiccator they use to knock off material before they then sterilize it. So if your instrument set has 35 instruments, that's 35 times 45 seconds every single time they do the case. The other thing is we kept track of how many instruments were bent or damaged after we reduced them, and it went down to almost 0. So they're moving as fast as they can, dropping stuff, banging stuff, bending it, trying to get all these instruments sterilized that you're not going to use. So minimizing it really has a big impact. So for those of you that are having like Andrew in your ASC, where you're doing a whole potpourri of ENT procedures, and your day could have a septoturbs, it could have a cochlear implant, it can have a mastoidectomy. Do you try to come about some form of order to the cases to keep the day flowing?
I think there's 2 things on that, and this is a big difference between the hospital setting and an ASC. We're talking about what the surgeon can do with the team. In my experience, the biggest delay is what happens between the cases. I don't know if you guys have carnal knowledge that I don't get, but that's where the delay is all the time, all right? So every year, we meet with the hospital staff and say, how much time have you allotted for our cases? And then we try and streamline that so everybody in our group has the same time allotted for that. Now, there might be some exceptions, but we send one list in to the hospital saying, here's how much time we need for tubes, here's much for a tonsil and adenoids, and we try and do that. And then that works for approximately 3 weeks, and then it goes back to that they lost the list and doesn't help. We have more success in the ASC, but absolutely this is a learning process, and this is where it will involve your office because this has a lot to do with your scheduler, all right? And you will know when you have a new schedule in the office because your schedule will be off in the OR. They'll put XYZ when you needed ZYX. And so training your staff, and then the final part of that in the ASC is the person that finally looks like the day before or 2 days, if it's Friday, whenever, to say what order did they put them in. Then you can make what I call game time decisions so that they can call the patients and change their arrival time so that they say, no, we're going to do the mastoid last and we're going to do all these tonsils, or this is an adult tonsil, so we'll do these kids, even though it's a longer case, we'll do those first. But that takes time with the scheduler knowing what is best and then working with the other department. Does that answer your question?
Mm-hmm. Anyone else?
Do you mean that your patients come in at an allotted time, so you estimate them to be in 10 o'clock, they'll come in for 9:30? About how we work it is, if we've got a morning list, they're in for 7:30. We do the rounds, check them, check consent, put the green band on, identification, mark the site, check that all the lab reports are there, and then the anaesthetist goes round as well, and then we have a huddle to make sure that we've got all the instruments correct and everything's go, and then we then have to call. So there's many faults. You could say, our children's ward, for instance, is 500 meters away. So we have to really make sure that if you're doing a tonsil, when you're taking out the second tonsil, you say, send for the next case. And then hopefully we don't have a proper pediatric pre-op waiting area like you did in your rooms. They're just 50 feet away of that. I think there's a lot of design faults within certain systems, and availability and having the patients next to you.
Another thing that we found to be extremely powerful is to take the 15 most common cases you do or 10 most common cases that you do. And if we really think about it, most of us have probably 5 most common cases we do. And sit down with the staff and say, when you're cleaning the room and sterilizing instruments and turning them over, what takes the longest? And what can we release in order to get the process moving while we're still closing the prior case? So the one that's always comes up big is re-sterilizing the drill. So as soon as we're done with the drill, we take it off the field, and they start sterilizing it while we're doing the rest of the operation. And I think the other thing is we're all just like technologically challenged in that every piece of technology seems to be cool to use. Do you really need to use it? Because that requires the staff to turn the machine on, turn it over, creates potential risk if you don't have it working properly. Facial nerve monitors, it's great, provided it's on, right? And we've gotten halfway through cases where we've looked over and the facial nerve monitor's not been on. So I think this is point number 3. We still haven't blamed the OR techs yet, is if you actually sit down and understand their process, and the only way to do that is to follow them around in between cases and see what they do. And say, wait a minute, if we release the micro instruments on the stapes early, they can start turning those over for the next case while I'm closing. Or if we're going to do testing on a cochlear implant, they could be getting instruments off right away and having somebody get those moving. The whole idea is to keep it moving. And the last thing that I'd like to bring up, and this is something that all my fellows have learned, is that we help them turn the room over. And in hospitals, they'll tell you, no, go sit down. Just be there and help. If you're a pain in their butt, they're going to keep working rapidly. So in our surgery center, I take the drape off the microscope, I take the handles off the light, I do everything I can that doesn't get in their flow of work that takes additional time to do. If there's stuff on the floor, I pick it up and throw it away. If they see the surgeon giving it enough time to see urgency and turnaround, I guarantee you that you will see benefit. Have any of you had experience with that as our last question?
Oh, yeah, it's important to be part of the team. Just gel with them to help transfer the patient over from, the OR table to the trolley. Do what you do.
Doug, we'll just run right down the panel. What do you think?
I agree as well, and it's easy. we're in a room where it's a teaching hospital. So there's residents with us, there's student technicians, student nurses, student anesthesia providers. It's easy from the physician standpoint to go to the wall and start putting orders in, get the brief op note in, and depending on how that's set up in the room, you may not be facing the patient. And so that's an awkward situation to be in. So it's a good reminder to manage both your tasks, but also help be aware of the patient. And I've seen that, if you take the drapes off or move things along, that kind of moves patients as well. I think the flip side of that is the nurses in the room or the techs may ask to undo things or take things away that can help you, that can hurt you. Make sure I've had situations where they take the bovie away or take something away and then a bleed happens, or now you have critical pieces that are removed from the field that now you've just extended your time immensely trying to reset those back up. So be mindful of what you undo or what you take off the field.
One thing I really want to stress, and I think it's really important, there's a difference between efficiency and speed, all right? I think taking a chill pill, I've learned as I've got more of these gray things up here, I got the hair, Doug lost all his hair, I don't know what happened with that. But you can be such a pain that it's counterproductive. You'll start losing staff, especially in the ASC, if you're pushing that hard, and that's also when mistakes are made. So I think it's very important that you differentiate between speed and efficiency and really keep in mind patient first and doing a good job.
Yeah, I don't think I have a lot to add. I work with residents almost all the time, so I'm very lucky in that way. But I think I would reiterate what Doug said. It's a team approach, and being there before the case, helping get things up, make sure there's nothing missing, and at the end of the case, same thing, trying to facilitate what's getting done, what needs to get done for the next case, with an ongoing communication. Because I would also agree that you don't want to be the person who's always just pushing. You want to be part of the team and kind of understanding what the constraints are against the other OR staff too, so they don't feel like you're just being impatient with them as opposed to trying to facilitate the process. So just ongoing communication with your team.
So Cliff is the perfect cue card for the closing point, and that is just do a little debrief at the end of the case. And I can tell you, in talking to our OR staff, nothing is more powerful than when the day is going bad. If you ask them in a non-offensive way, what's up, what should we be thinking about, and they tell you a problem and you acknowledge it, you say, oh, that's tough. Okay, just let me know. Suck it up, don't get angry, walk away. You validated them, and it's a really big deal. So thanks for panel number one. We're going to race into Dan Zeitler, who's, I'll let him introduce himself. He's from the Lister for Life Center at Virginia Mason, and he's going to